Dr. Mandil is a professor of epidemiology at the High Institute of Public Health, University of Alexandria in Egypt. He's also the adjunct professor of epidemiology and population health at AUB Faculty of Health Sciences. He was former coordinator, research and innovation, and former secretary, Research Ethics Review Committee for the WHO Eastern Mediterranean Region Office in Cairo, Egypt from 2014 to 2023. He received his bachelor's degree in medicine and surgery in 1981 and master's in pediatrics in 1985 from Alexandria University in Egypt. Subsequently, he received his doctorate in public health from University of California, Los Angeles, UCLA, School of Public Health in 1991. He served as a secretary, International Epidemiology Association from 2022 to 2008, from 2002 to 2008, and currently serves as a board member, peer reviewer of scientific journals, including the WHO Eastern Mediterranean Region Health Journal, the Journal of Epidemiology and Global Health, as well as the Journal of Family and Community Medicine. Dr. Mandil, thank you for being with us today. The floor is yours.
Thank you very much. Can you hear me, Dr. Summer?
Yes, very well.
Thanks very much for giving me this opportunity to address your series today. This afternoon, we're going to look at the progress and way forward, predominantly on the SDG 3, which has to do with universal health coverage. So we're going to talk a little bit about the situation of the Eastern Mediterranean region, some background factors, an overview, dashboard, and indicators related to universal health coverage, the situation in the Eastern Mediterranean of its indicators for performance assessment, and finally, some limitations and gaps. So, as you all know, our region has all kinds of problems, unfortunately. It's a region where there are so many emergencies, crises, and sometimes even disasters. We're going to talk about this in a minute. The re-emergence of lots and lots of communicable disease outbreaks after we thought that we're done with CDs and we concentrate on NCDs. There are lots and lots of economic crises in several countries of the region and sanctions against some of them. And as you know, globally, regionally, and nationally, we are all suffering from the effects of climate change and environmental degradation. The region has almost half of the world's refugees, migrants, and internally displaced persons, better known as IDPs. The epidemiologic and demographic transition is affecting most, if not all, countries in the region. And then there are lots and lots of scientific and technological problems. As far as emergencies are concerned, there is more than 100 million people in the region out of 400 million who need assistance. We definitely suffer from half the deadliest natural disasters during 24, 16 graded emergencies, 75 communicable disease outbreaks, and more than 1,000 attacks, unfortunately, on healthcare professionals themselves, as we have seen in Gaza and we have seen also in Lebanon. You know, for the last year and a half, there has been ongoing war, both in Gaza, in Palestine, as well as in southern Lebanon and many Lebanese cities. You know this more than I do. But also there are different factors which affect the region, some of which are socioeconomic, others are geographic, and some are gender related, but there are also cultural and religious factors which affect health and well-being of the people who live in this part of the world. And the Eastern Mediterranean, ladies and gentlemen, includes all Arab countries as far as WHO is concerned, except Algeria, Mauritania, and the Comoros Islands, which are members of the League of Arab States, but not the WHO Eastern Mediterranean. They actually belong to the African region of WHO. In addition to 3 non-Arabic speaking countries, Afghanistan, Pakistan, and Iran. As far as disparities from a socioeconomic perspective are concerned, as you know, unequal distribution of wealth and resources, compare GCC with countries like Somalia, Sudan, and Yemen. There is also great disparities in access to healthcare and health outcomes, If you are non-insured, non-employed, then not necessarily that you get the best of health services, and you know this better than I do. There are also geographic disparities for people who live in rural areas and remote areas, and if they were internally displaced or migrants. There are also some gender disparities where women and girls may face specific health challenges, including maternal mortality, reproductive health issues, and even GBV. There are also cultural and religious factors. The norms and the beliefs could influence the way people behave and the way people access healthcare. And we have seen this with things like immunization and similar, healthcare services. But there is a big rationale for addressing health equity and using the Sustainable Development Goals by 2030, trying to achieve the universal health coverage. The rationale is to address and to achieve political stability, to have good economic benefits, to achieve social justice, and also it's an ethical question. As far as political and conflict instability, health equity is very important to avoid the disruption of healthcare systems, and which leads to increased morbidity and mortality. Ethically speaking, health equity would ensure that everyone has the opportunity to attain the full health potential as a fundamental human right. Economically, when you invest in health equity, this could lead to increased productivity, reduce poverty, and help economic growth. But also when you address health parities, this is essential for building just and equitable society. And hence, the Sustainable Development Goals have been actually put together more than 10 years ago. They were preceded, as you all know, by the Millennium Development Goals. Now we're talking about the Sustainable Development Goals, and hopefully that we can achieve universal health coverage as well as health equity. I'm sure all of you have seen this diagram before, but I don't know how many have thought, why is the SDG 3 in the middle of this circle? Ladies and gentlemen, when we have 17 goals with 169 targets, which all member states of the United Nations, including WHO, have agreed upon, trying to achieve them as 2030, each and every of these goals affects health, which is the Sustainable Development Goal number 3, directly or indirectly. So good nutrition affects health, good education affects health, safe environment affects health, access to sanitary water affects health, etc., etc. So all Sustainable Development Goals support the Sustainable Development Goal number 3, which is health related, which is designed to ensure that healthy lives are achieved and promote well-being for all at all ages. And here we're talking about a life course approach to health, min al-mahdi ila al-lahdi, for different people in different locales, different countries across the globe. Now, let's move to the Sustainable Development Goal number 3, which is designed to achieve universal health coverage. Now, universal health coverage has 3 main things to think about: equity, quality, and financial protection. So UHC means that all individuals and communities receive the health services they need in good quality, to be effective, and without suffering from financial hardship. And hence, there are 2 main indicators to assess the performance towards Sustainable Development Goal number 3 and the possible achievement of UHC. One is called 3.8.1 for the healthcare service coverage, and the other is called 3.8.2 for financial protection. And as you can see on this slide, on the right side of it, that we have 3 dimensions of the UHC. The equity and fairness in services use, which means that we'd like to reduce the gap between the need and utilization. The quality of provided healthcare services, sufficient to improve health and maintain well-being. And most importantly, financial protection, that no one becomes poor as a result of paying for care, what we call out-of-pocket expenditure. But let us, ladies and gentlemen, think of what universal health coverage means and what it doesn't mean. Ladies and gentlemen, UHC means that we should be able to get promotive, preventive, curative, rehabilitative, and palliative healthcare services equally, that such services are covered through certain routes of finance, that it is about all components of a healthcare system, progressive expansion of coverage of healthcare services, and social inclusion and equity, as I've just mentioned in the last couple of slides. But UHC does not mean that health services are free. It doesn't mean that UHC is about individual treatment only. It doesn't mean that it's only about finance, and doesn't also mean that it is limited to the minimum package of healthcare services and that it is only about health. As I mentioned with the Sustainable Development Goal number 3, it is related to all Sustainable Development Goals of education, of nutrition, of environmental stability, of the effects of climate change. All goals affect SDG 3 and affect the achievement of universal health coverage. How about health security? Well, health security encompasses the activities required to minimize danger and impact of acute public health events that endanger the collective health of populations living across geographic regions and international boundaries. And this has been established through what is known as the joint external evaluation of the international health regulations, which all member states of the UN and WHO agree upon and go by to the best of their ability. And when you are trying to achieve health security, this means that you are trying to do specific preventive, mitigative, preparedness, response, and recovery activities, which represent the phases of the public health response to disasters and emergencies. In order to address the socio-cultural, the socio-economic, the ethical, as well as the different factors which I described in prior slides, in order to address such challenges, this, ladies and gentlemen, requires a multifaceted approach where we would like to strengthen primary health care. So we invest in primary care to improve access to essential services and prevent disease. We would like to improve health finance by expanding health insurance coverage and reduce out-of-pocket expenditures. We'd like to invest in human resources for health. You know, and I know, that our part of the world has suffered a lot from brain drain and people moving from less wealthy to more affluent communities where they have better, income. So training and returning healthcare workers, particularly in underserved areas, such as the rural and the remote communities. We'd like also to empower individuals to make informed health decisions, as well as addressing the social determinants of health to address poverty, education, and environmental factors, which would definitely improve health towards the achievement of UHC. On this note, the World Health Organization would like to focus on primary health care to improve accessibility to quality essential health services, working towards sustainable financing mechanisms and financial protection of individuals, families, and communities, improve the accessibility to essential medicines and health products, train healthcare force and advice on labor policies, whether we're talking about physicians, pharmacists, dentists, nurses, medical lab technologists, and the like, support people's participation in national health policies, and improve monitoring data and information systems and services. Now, as I said earlier, the target of 3.8 of the universal health coverage tries to achieve the UHC, including financial risk protection, accessibility to quality essential healthcare services, accessibility to safe, effective, quality, and affordable essential medicines and vaccines for all. And hence, when regions and countries try to assess the performance towards UHC, we have something called the dashboard. And here, the dashboard is used to track progress towards achieving the UHC goals globally, regionally, and nationally. And this includes 3 sets of metrics: the accessibility of essential services, the financial protection, as well as the health system efficiency and quality. As far as accessibility of essential services, this includes the maternal care, vaccinations, but we're going to talk about this in details in a little while. Financial protection to avoid catastrophic health expenditures, as well as the health system efficiency and quality metrics, which have to ensure good quality of provided healthcare services for different echelons of the society. Now, when a country has a dashboard to universal health coverage, this includes the commitment progress towards the indicators, the institutional efforts to achieve UHC, priority services and population groups and equity, public perception and social participation, as well as multi-stakeholder collaboration for UHC. And as I would like to mention here, it's not one size fits all. Every country has its own specifications of its dashboard according to the main healthcare providers. For example, in Lebanon, the private sector is probably more important in healthcare delivery as compared to other countries where in the GCC or Egypt, the public sector plays a more important role in delivery of healthcare services compared to the private sector. And hence, achieving UHC would be different. Now, how do we actually assess the performance towards universal health coverage? What are the indicators we use for such performance assessment? First of all, we have what is known as the Service Coverage Index, where we have a regional average and average in countries with the same income level. We're going to talk about it in a minute, inshallah. How do we assess financial hardship? By the percentage of households experiencing financial hardship due to health spending. How do we assess general government health expenditure? By the percentage of national budget allocated to health. How do we assess out-of-pocket payments? By the percentages of health expenditures financed by out-of-pocket payments. And primary health care is usually assessed by the percentage of health expenditure allocated to primary care. Now, as far as the Service Coverage Index is concerned, this is a composite index of indicators, including the assessment of reproductive, maternal, newborn, and child health. And examples of indicators include demand satisfied with modern methods among women 15 to 49, yani the reproductive age, who are married, as well as the antenatal care 4+ visits %. Communicable diseases indicators include the TB treatment coverage %, people living with HIV who receive antiretroviral therapy %. For NCDs, you know, of course, that this includes diabetes, hypertension, cardiovascular disorders, cancer at different ages, mental health problems, etc. So indicators could include things like mean fasting plasma glucose, prevalence of treatment for hypertension among adults, and so on. As far as the service capacity and accessibility is concerned, this is usually measured by hospital beds per capita, as well as the International Health Regulations Core Capacity Index. Now, in the next few slides, we will actually look at specific indicators which cover different aspects which are related to universal health coverage. For example, we start by policy and governance assessment. The indicators would include evaluation of health policies, funding mechanisms, governance structures which support UHC. How do we achieve this? By reviewing national health strategies, national health accounts, to assess alignment with universal health coverage goals. How do we assess HIS? Well, this is through the robustness of data collection systems related to health outcomes, service delivery, and population health statistics. And how do we do this? We use the electronic health records or electronic medical records, whether EHRs or EMRs, national health surveys, which track the UHC progress. Now, we also have the health workforce density, which is assessed through the number of health workers, whether physicians, nurses, midwives, pharmacists, dentists, medical lab technologists per 1,000 population. And we use this by tracking health workforce statistics to ensure adequate staffing levels in health facilities. Now, how about health equity in health coverage? Here, we look at disparities in health service coverage among different socioeconomic groups, geographic regions, or genders. And how do we do this? Through analysis of accessibility to health services in rural versus urban areas to highlight inequities. And rural also include remote as well as migrant settings. Now, how do you assess access to medicines and vaccines as one of the essential healthcare services? Here we assess this by the availability of essential medicines and vaccines, as well as affordability of these health products, and preferably provided by the public sector. The example is through monitoring the percentage of health facilities that have a core set of essential medicines and vaccines which are available to indicate the accessibility levels. How do we assess quality of care? Of course, this deserves a presentation all by itself, but in a nutshell, we look at things like patient satisfaction surveys, clinical outcomes, adherence to clinical practice guidelines, and so on and so forth. So here we assess patient feedback on service quality in hospitals and clinics as an example. As far as financial protection is concerned, which is one of the 3 pillars of UHC, as I mentioned earlier, this measures the extent to which the healthcare costs prevent households from accessing healthcare. The key metrics include out-of-pocket expenditures as a percentage of household income or proportion of population that face catastrophic health expenditures. And for this, we use surveys to assess household expenditures in different countries, whether on a national, subnational, or provincial scale, to provide insights into financial protection. What I mentioned so far, as well as UHC performance assessment, needs joint work by different stakeholders, which actually play different roles in support of the road towards UHC. This definitely includes the public sector, which prioritizes data collection and reporting systems. This includes the private sector. This includes international organizations to provide technical assistance and funding. And this includes definitely the WHO, the UNICEF, the UNDP, the UNEP, and others. Academia and researchers to develop innovative methodologies for measurement, as well as the NGOs and CSOs to advocate for equity and transparency in UHC implementation. So in essence, in order to achieve UHC, this has to include the different stakeholders in the community we are talking about. WHO have produced different reports for the global monitoring of UHC in 2019, 21, but the most recent is 23, and there is also one on 24 to track the universal health coverage globally, regionally, and nationally. And I actually invite you all. This is public access reports, and they are very, very useful and comprehensive. How about the progress towards universal health coverage? Ladies and gentlemen, the expansion of health service coverage has largely stalled, unfortunately, since the launch of the SDGs about 9 years ago or 10 years ago. The financial protection for those who do receive health services has unfortunately deteriorated. Recent data shows as of 21, about half of the world's population, more than 4.5 billion people, were not covered by essential health services. And just 5 or 6 years ago, 1/4, which means 2 billion people, experienced financial hardship due to out-of-pocket expenditures. The world is currently, unfortunately, off track to make significant progress towards UHC, and the proportion of population that faced catastrophic levels of out-of-pocket health spending has unfortunately increased. Now, as far as our region is concerned, the Eastern Mediterranean, the progress towards UHC has been not fast enough, with financial protection not going really in the right direction. And this is something really to keep in mind. And this is mentioned in the global report, which I referred to in the prior slides. The Eastern Mediterranean demonstrates a slower increase in service coverage index compared to other regions, unfortunately, and a relatively high increase of the different parameters we spoke about, which includes financial protection. Now, the approaches which I've just described have some limitations. For the coverage indicators, measuring the proportion of population accessing certain services may not reflect the quality of the provided services. Assessing the financial burden of healthcare individuals may not capture accessibility to quality services, and reflecting overall population health may not directly link to UHC implementation. So these are things to actually keep in mind as we use the indicators which I've just described. When we actually used review of the UHC indicators, we noticed that there are certain gaps. Gaps in the service type, especially rehabilitation and palliative. So the preventive, promotive, and curative were doing much better than rehabilitative and palliative healthcare services. The mental health and injuries were not receiving enough care compared to other morbidities which are handled by the different levels of healthcare delivery systems. Older people, specific indicators aren't really there, unfortunately, whether you're talking about 60 above or 65 above. And the need for disaggregation criteria, as only 20% of reported indicators are broken down by sex, age, education, or wealth. These are things to keep in mind as gaps in using these indicators, which I've just described. And hence, we have a call for action. We should work together to develop and implement robust indicators that guide us towards a healthier future, invest in data systems for UHC monitoring, promote health equity focused policies, and collaborate across sectors and stakeholders to ensure that no one is left behind. As I said earlier, UHC means that everyone everywhere can receive quality healthcare services when and where they're needed across the life course من المهدي إلى اللحدي without facing financial hardship. Reaching the goal of 2030 of universal health coverage requires proactive, targeted, and accelerated efforts building on strong data and strong evidence. And hence, reaching such goal requires substantial public and private sector investments, accelerated action by governments and stakeholders, reorienting health systems to primary health care, to advance equity in both delivery of essential services and financial protection. Achieving universal health coverage also requires modern, fit-for-purpose health information systems for health that provide timely and reliable data to inform policy design. Such shifts, ladies and gentlemen, are essential as we continue to respond to challenges posed by deepening macroeconomic, climate, demographic, and political trends which threaten to reverse hard-won health gains globally and regionally during the 20th and the beginning of the 21st century. Ladies and gentlemen, last December, the world has celebrated the Day of Universal Health Coverage with the slogan of health, it is on the government rather than on the house. We tried this afternoon to look at the situation of the Eastern Mediterranean, background factors, an overview of universal health coverage, its dashboard and its indicators, the situation in the Eastern Mediterranean region, limitations and gaps, as well as the way forward. And these are a few, references if you'd like to learn more about what I've just covered this afternoon. Dr. Samar, ladies and gentlemen, thank you very much.
Thank you so much, Dr. Mandil, for this comprehensive presentation on universal health coverage. I think I'm just going to open the floor now for questions. So please, if you have any question, you could kind of unmute yourself, or you could kind of raise your hand and or possibly post it on the chat and I'll read it. Okay. So I think let me start with the question myself here. I was like wondering what would be the really facilitators and barriers for universal health coverage within the Eastern Mediterranean region and the different countries and regulations in terms of health.
Thank you very much, Dr. Samar, both for inviting me to today's presentation on this series and for your question. I think the facilitators have been actually mentioned, although in brief, during the presentation itself. It's a multifaceted approach towards universal health coverage, which needs the joint work of different stakeholders towards UHC, the joint work of the public and the private sectors, the economic support and investments in health, the support to be given by academic research institutions, as well as NGOs and CSOs. But also we have to say that there is a lot of technical assistance which could be provided by different UN agencies, including WHO, the UNDP, and UNICEF. I hope I answered your question as far as facilitators are concerned.
Yeah.
Barriers include the background factors which I described at the very beginning of the presentation, some of which are sociocultural, some of which are economic, some of which has to do with emergency situations, the humanitarian settings, and also the economic hardships which many countries of the region suffer from, especially related to all kinds of emergencies, crises, and disasters. We have seen what is happening in Gaza and Lebanon. We have seen what is happening in the Sudan, Yemen, and Somalia. We have seen what is happening in Libya and in other member states of the region. So all of these actually counter the gains which were achieved over the last decades. Now, unfortunately, as I described in the last couple of slides, the achievement of UHC by 2030 seems to be quite challenging.
Yeah, that was exactly the concern, especially with the kind of evolving situations in the region. So what would be the kind of, additional barriers to really implementation of health coverage? Okay, thank you.
Sure.
So any questions or comments? We have a quiet group today.
I actually had the same question as you, Samar. Because Dr. Mandil mentioned that, both mental health and injuries are receiving the least attention in terms of universal health coverage. So I wanted to ask him about his thoughts about the barriers and facilitators. So that was answered. Thank you. I think you have a hand from Nora.
Okay. So I think the mental health is also like a major issue that could be kind of also discussed.
Exactly.
Okay, so I'll
take that. This is why we call for integration of mental health care into primary healthcare services and the training of family physicians as well as the family practitioners on how to handle the ordinary anxiety and depression, which could be handled at primary care level before going into psychiatrists and neurologists. So integration of mental health care into primary health care could be one way to support these kinds of services towards UHC.
Yeah, especially in this region. All right, so I think I'm gonna take this question from Noura. Please, Noura, unmute yourself and please ask the question.
Dr. Noura Markarian,
Okay.
are you the one?
We cannot hear you. Yeah.
My mic now is it
Yes.
hearable?
Yes.
Oh,
Yes,
yeah.
yes. Please go ahead.
Okay, my dear doctor. What you're saying, I'm a political science and public administration alumni from AUB, and I'm in Dubai, and I'm hearing you. So I'm a lecturer also in several universities.
Yes.
So what I've heard from you is that it's the wishes. You're wishing, but there is no evident or change happening till now. That is in everything, in every sector, economic, political, health-wise. So what is the problem, dear professor? What shall we do to start something? We are wishing, we're, and waiting for that thing to actualize. So because of the economic situation, political situation of the region. What is the best solution for us to enhance something and start the baby steps forward in this particular webinar?
Thank you, Dr.
I'm
Noura. Please go ahead. Sorry for that.
No, that's the thing. So because I want change to happen, to have a rebel in our hearts and start some baby steps towards change. This is what I say to my students, that if you don't start somewhere, and you're starting, but must we wait a couple of years till the region is settled and a new political realm is gonna, come over us and then start again? What are we doing? Are we wishing, or are we? Do we have to fight? Do we have to start somewhere?
As a matter of fact, Dr. Noura, I think you have already answered your question yourself by mentioning that we as health professionals at different levels of the healthcare delivery systems, or whether we are in health facilities or in academia or research institutions, should be UHC should be a target we all try to achieve one way or another. Because many people think that the government will do it on its own. Although the slogan of UHC for 2024 was, it is the government which should support UHC, but obviously it cannot do this alone. It should be a joint effort by different stakeholders, but maybe my presentation was more on the macro level, but on the micro level, each and every health professional has a responsibility towards UHC. So if we are well trained, if we do our best to give the best quality of health services, if we make sure that accessibility is across the board, whether we are insured or not, employed or not, expat or ولاد البلد, then I think this is very important towards UHC. So probably each and every one of us has a role on the micro level towards the macro level and achievement of UHC on a national level or regional level or even global level. So this is my humble response to your question, and I think it's a very important one.
Thank you, Dr. Mandil. Noura, Dr. Noura, I think you have your hand also raised. Like, do you have another comment or questions, or it's just like from before? Okay, I think it was just like from before. So I think what Dr. Noura is referring to mostly what could be the kind of concrete steps towards, achieving that universal health coverage, especially with the discrepancy in terms of, different countries in the Eastern Mediterranean region, high income countries and low income countries, zones, and like a conflict zone and war and like others. So that could be, what could be the concrete steps towards that?
This is a very important question, Dr. Samar. Basically, the discrepancy you have just described is one of the most important challenges. If you go to GCC, the Gulf Cooperation Council countries, as if you have moved to another planet. And if you go to the countries of the region which are among the poorest, such as Sudan, Yemen, and Somalia, this is a totally different planet. But there are countries in between. These include Lebanon, Egypt, Tunisia, Morocco, and the like. I think the achievement of universal health coverage is possible if there is joint work by the different stakeholders, if the different public sector works together. So we're not only talking about the health sector, we're talking about the economic sector, we're talking about the planning sector, we're talking about the education sector, we're talking about the nutrition sector working together. This could make UHC feasible and possible. It is so unfortunate that the emergencies in the region has been pulling back the achievements over the past decades, which we have achieved towards accessibility, affordability, and satisfaction with healthcare services, and also the reduced morbidity and mortality for most of communicable diseases. It is so unfortunate that the emergent situations and the emergencies and the economic crises have pulled back many of these achievements. So let's be optimistic, nevertheless, and do our best on the individual level towards the achievement of UHC, inshallah.
Absolutely. I think this is the only way forward. Okay. So any other comments or question? Okay. So let me just check the chat. Okay, so I just want to conclude by saying, reiterate my sincere thank for this insightful presentation. It's like it kind of raises more questions also
Yes.
for the audience as well. So thank you again, and thank you for joining us. I just want to thank you all for being here today. So we'll see you next week, and take care. Have a good day.
Thank you very much for giving me this
Thank you
opportunity.
again. Thank you. Bye-bye. Bye, everyone.